Shall we move on to the discussion segment right now? Because we have some 15 minutes time with us. The cases that we have heard so far can now please be discussed by our respected chairpersons and panelists. Thank you.
Shankar here or the chairperson? Devasith are left. Shankar here or not?
No, I think Dr. Mondal is not here. So you and Dr. Shoma Patro, you'd be here. And then we have a 15-minute break for tea after this. But yeah. So you still have 8 minutes in your hand for discussion.
Just have to start in the way. But there is two or three questions that come in the chat box I have read. About the IV, also about the SGLT2 with the fifth period of success, the heart failure therapy. In the last slide, the Dr. Hema already indicated, actually diuretic therapy along the MRA and SGLT2 along with the RNA, the fourth period of success, the heart failure therapy. So there is a question whether we can use the SGLT2Y in terms of heart failure, and we have found the kidney renal protective effect and just decreasing the interglomerular pressure and just causing the creatinine much less in time scale. So we can use SGLT2 the heart for the DAPA, HF, and decleatommy already proved that in that way with the cause of the similar the renal protective of the heart failure therapy. The one the question the chat box. And this IV amiodarone. So more take up the question of IV amiodarone. So whether you can use the IV amiodarone that the rhythm control therapy, but it is also myocardially sufficiently depressive. So whether the heart failure we should use the amiodarone in atrial fibrillation or not. Is Shoma here?
Yes, sir. Actually, IV amiodarone we are giving for our atrial fibrillation patient for a short duration, maximum our mostly with a couple of bolas, then the 24 hours and most of the time the patient will improve. And during this time, especially the patient is having atrial fibrillation with acute heart failure, we also need to give other vasopressor support most of the time if the patient is not maintaining blood pressure. But if the heart rate is more, the cardiac output will go down. So we need to reduce the rate by any means. And if the patient is hypotensive, then we may need to stop them. But by the way, the question was by one of the colleague that whether we can give cortisone or not, but definitely cortisone has a role, especially if there is a ventricular rate, and sometimes we may need to continue during the oral therapy during the maintenance of the patient who are on atrial fibrillation. But already Dr. Basavendra has explained that some of the times we may go for, if the rate is not under control, we may need to go for RF ablation, avinodal ablation, and then we need to put the CSP or CRTP or D.
There's only one question from the Basavendra is not here. Basavendra existing? Basavendra here? So just one question for you. Whether in the age of 70, say the age related to hypertensive AF, whether he will opt for the limb control or rate control.
Can you please repeat the question?
Just at the age of 70, age-related atrial fibrillation, when right atrial and left atrial stem is much more and size is much, and the hypertensive patient, whether you opt for rate control or rhythm control.
So that will depend upon whether what is the structural heart disease. If the patient is having structural heart disease, significant valvular involvement, I think rate control in this group will be a fair enough option. However, if the patient is having a structurally more or less normal heart and the symptoms are new onset and we feel that the symptoms have worsened with the development of atrial fibrillation, then we can opt for a rhythm control therapy. Now, important things are if the patient is coming to the emergency, then before starting a rhythm control with maybe IV amiodarone, we first have to rule out LA clot.
Yes.
If we are not being able to rule out, at least we should give a prophylactic dose of heparin. And keeping in mind the GFR, overall body weight and other comorbidities, we have to adjust the rate of infusion. And after stabilization,
but the more aged person more than 75, if the rhythm control is attempted by dofetilide or rather IV duranderon, it advancement is much more prominent than just giving a simple beta blocker along with some digitalist. We can go for it along with some anticoagulant.
So with ibutolide and other agents, the torsedis is more common as compared to amiodarone, and we are more comfortable with amiodarone as of now.
Right. Just one question of discussion, Dr. Hema, is regarding whether in acute heart failure and the left ventricular failure, hypertensive or infarct related, whether it will go on for torsemide or the furosemide.
As I told you, sir, there is no better efficacy wise. There is no a difference between furosemide and torsemide. But then for follow up, except for the decreased hospital stay, which is also a very minimal percentage. So you can use torsemide or furosemide. Only the dosage difference.
And the same efficacy or efficacy is something
It's the
different?
same efficacy. It is a little better, longer acting. Otherwise, the efficacy wise, it is the same.
Okay, thank you very much, Chupro. We have discussed the chat box questions, and only one. Priyomi is not here. The Priyomi is one question to be for hyperkalemia in the heart failure, the hyperkalemia. Whether CKD, when the creatinine value is more than 6.2, then whether he will use the MRA or not.
Yes, I am here, Dr. Roy.
Oh, you're
Yeah.
here. You're not raising your file. And
Yeah.
so whether your creatinine is 6.2 and you're using RNA is much less fatal than MRA, and whether you add back the creatinine is dropping down to 5 or 5.5, then you use a MRA or not.
See, the two molecules, this RNA and this MRA, the both have a standard recommendation. Now, the CKD is basically a defined ball game. CKD totally different ball game because I think this if you see the RNA group, so even in CKD, though recommendation wise we are not supposed to use when the creatinine clear is less than 25 or creatinine is more than 3, still nephrologists are using it, and we are also actually recommending it nowadays because we have seen the CKD diabetic patient with a reduced ejection fraction, they do have a significant benefit if you continuously earning. But the issue is again the issue is the potassium. Again the issue is the potassium. So CKD patient on dialysis, there is no problem. On regular standard dialysis, there is no problem.
And if the potassium is,
Yeah,
and if the
no-
potassium around 4 or 4.5.
Yeah. If the patient is on adequate dialysis, there should not be any potassium issue. But if the inadequate dialysis, there maybe there's sure there will be potassium issues. So you can continue. But regarding this is very interesting because your MRA, particularly now the Kerendia or the Finerenone is coming in the market, and he has showed robust benefit both kidney outcome and your cardiovascular outcome. If you start in the diabetic patient with your CKD, still in this Finerenone group, the inclusion, if you go through the inclusion criteria, they have excluded patients who have a EGFR of less than 25. So in an advanced stage 5 CKD, still there is no significant recommendation for the use of MRA. If you check the potassium, if I take with the for argument, check for argument that you can check potassium, still even if the EGFR is less than 25, there is no standard recommendation. You can use off level because somebody can argue that it may lead to delay the dialysis initiation of dialysis, but still there is no recommendation. Not a standard guideline recommendation to start your MRA, even Kerendia or Finerenone, when the creatinine is around 6. Unless it is an acute renal failure or acute on CKD, then you can actually reduce the creatinine and then restart. So this is the opinion.
Okay, thank you very much. You are conveyed very much. You're well conveyed here. Over to host for the time is up, I think, for the session. Over to host for starting the second session. The football is already taking some tea break, will be there.
Yeah. Thank you very much.
Yes, now we will
Thank
break
you,
for
Dr.
a short break, a tea break or a coffee break. And after that, we will again be back on time at sharp 6 o'clock and we will resume our session. Happy learning. Stay tuned. See you all at right 6.
Tea break is virtual.